So welcome to our segment on COVID and mental health. We have with us today Stephen Williams, who former colleague of mine and a friend for the 10 years that I've lived here in Buffalo. And one of the people who actually helped me transition to Buffalo, where I knew absolutely no one. And Stephen and his academic happy hours, which have gone by the wayside, but that's okay. I'm old enough to know how to go to bars all the time. Was very helpful in grounding me here in Buffalo, and I'm grateful for his continued friendship. And Shannon King, who is a new friend who I met through the trip for alumni to Cuba in December and January, who also kindly kept me sane on that trip. So if you'd like to kind of introduce yourselves a little bit about what you do in terms of mental health therapy, and then we can open the conversation.
Go ahead, Shannon.
So I am a clinical psychologist, and I currently work at Erie County Medical Center, ECMC, with the BRAVE program, which stands for Buffalo Rising Against Violence at ECMC. And it's a hospital-based violence intervention program. So we see individuals from all over the Western New York area who have been victims of domestic violence, sexual assault, physical assault, and then also gun and knife violence. So we are very heavily involved in the East Side community of Buffalo as well. We partner with a community organization called SNUG, which is guns spelled backwards. And they work specifically with the youth in the population to try and, encourage continued education, going back for your GED, job skills, and just that general support that a lot of individuals don't seem to have.
And how long have you been a therapist, Shannon?
Oh, that's a good question. I graduated in 2017. I received my license in 2018, and I've been working independently on my own license since then.
Okay, thank you. Stephen?
So I'm Stephen Halliday. I'm a licensed clinical social worker. I've been working as a clinical social worker for about 5 years now. I work currently at Horizon Health Services as a mental health outpatient clinician, and prior to that I worked at our residential rehab, so background in both working with both mental health and substance use. Prior to that, which is how I first met Richard, I had gotten my PhD in philosophy and taught a few different schools. I was at Canisius for a while, so that's how I know Richard originally, before I quit my full-time job there and went back to get my MSW, Master's of Social Work. So in addition to my clinical work, I also am a part-time instructor at the online MSW program out of Edinburgh University. And so just in my clinical work, it's very general, community mental health. Some of the areas I work on are with motivational interviewing and cognitive therapy, and also bringing in solution-focused and positive psychology frameworks. So if you're a clinician, I'm sure you know what that means. If you're not a clinician, I'm sure you don't need to care about what that means. But that's how I spend my days.
Wonderful. Well, thank you both for participating in this. I wonder, maybe start off with a general question about how the coronavirus, the quarantines that resulted, the social distancing, the stay-at-home orders, how you have seen that impact clients and their mental health. I know that there's a lot of concern about how these social consequences of the virus have impacted everyone in the community, but in particular those more vulnerable and prone to some of these issues, and how also you are trying to address some of those issues. Shannon, if you want to start.
Sure. It was actually very interesting because, normally when we do therapy, right, and Stephen, I would love to know if you've had this experience as well. We're more removed from the situations that our patients or clients are going through. And yet this is something I was going through it right alongside all of my patients. There was just so much uncertainty and this understanding that we couldn't necessarily plan for the future, right? There's this fear and anxiety. I was encouraging individuals to stop watching the news and to find one trusted news source, because there was so much different information that was coming in. And so anybody who had been managing previously before COVID hit was starting to ramp up with anxiety, depression, and then anybody who was not managing very well, it just exacerbated the situation. It was very interesting to see how isolation in particular was starting to increase decompensation among some of the people that I was working with.
Stephen, have you experienced similar things with your clientele?
Absolutely, yeah. And I know I don't have the specific numbers, but I know that deaths by suicide and deaths by accidental overdose, at least in our population, have gone up over the last couple of months compared to where they were last year. I was just talking with some colleagues who were looking at those numbers. So, I'd echo everything that Shannon has said, and there are some very serious impacts, especially because a lot of the people who are most in need of help and most vulnerable, because mental health is not just about what's going on inside of our heads, it's about our relationship with our environment. So the people who need the most help and are most vulnerable are oftentimes the people who are least well equipped to make those changes. And I found many of them simply don't have the technology to be able to reliably do sessions by video like we're doing or over the phone. So one of the big things that I've seen is that the people who most need treatment and most need support have the least amount of access to it. And that's true both in terms of the mental health work that we do, but also people who are in addiction recovery, not being able to get to self-help meetings, not being able to stay in touch with supports who are typically their lifelines when they're struggling. You reach out, you go to a meeting, you connect with someone, and that's exactly what the quarantine measures have, in a sense, taken away or made really, really difficult. And more difficult because the people who need the help the most are often in positions where making those changes are really tough because of their circumstances and because of their struggles. So there's definitely been a large barrier to people getting the help that they need, that is disproportionately affected the people who are already the worst off.
Mm-hmm.
So given that, what are some strategies that you have tried to use with your clients to get them at least some modicum of assistance? I mean, I know that there's counseling through text messaging, which seems to me rather problematic. But also, Stephen, you mentioned not having access to the technology, but I also wonder, like, people don't have access to just general coping mechanisms, like going to visit friends or going to the restaurant, or just sort of what many consider normal social interaction. So what strategies do you suggest or do you try to utilize? Stephen, you want to start?
Yeah. A lot of the work has been doing the research and getting connected with what opportunities are out there. I know, like, I don't think a day goes by where someone on my team hasn't shared, oh, here's a resource that folks can use. And actually it's almost a full-time job in and of itself to keep up with all of the new things or the things that we didn't need to be aware of before. Just services, opportunities, programs, phone apps, and so forth that can help to fill in those gaps that the immediate social interactions have taken. or have that we've lost there. Another strategy, something else that has been a big part, is just kind of changing our conception of what therapy or what clinical work needs to look like. You know, sometimes just a 20-minute check-in where we're not necessarily doing like mental health treatment work, but, you know, I'm thinking of one patient in particular who, you know, he said, it's like, I just need someone to talk to. And you would sit there and talk. And it was one of the most important things for this person, because that was the only human interaction that they had all day. And just to have someone there. And I think this, whether you're a mental health professional or not, something that you can do, which doesn't require any special training, but just keep showing up. Just keep reaching out and keep finding ways. And it's not going to be perfect, and it's not going to be what you want, and you're not going to be able to hug everybody. But just keep showing up has been a big factor in what I've been able to do.
Shannon, what have you noticed in terms of therapeutic responses?
You know, it's interesting. You know, again, I agree with everything that Stephen's been saying. You know, we're so disconnected from our normal routines and our everyday lives, and that includes then social interactions, right? When we need people the most, we're told we can't interact with them, right? And, you know, I think, you know, particularly, like, so I also work in private practice, and to see the disparity, it's even more emphasized than it had been before COVID. You know, the individuals that I work with at ECMC tend to come from a lower socioeconomic status, different cultural and racial, ethnic backgrounds. And, you know, as Stephen was saying, like, trying to find ways to encourage coping. You know, for me, it has been kind of, you know, thinking outside the box. I have been doing some text message therapy, which is less than ideal. You know, phone conversations, individuals that don't have access to any technology or internet access, right? Finding ways to bring them in at a socially safe distance, you know, just to be there, to be that support for them.
So both of you have talked in different ways about the importance of community in terms of therapy and coping mechanisms and strategies, and how shall I say this, the unequal access to alternative ways of community building for different populations. I have several questions here, so I'll try to like do one at a time here, but I wonder if you notice a different approach to both the stressors and the therapeutic responses, whether your clients are male or female.
You know, that's an interesting question, and one that I'm not sure I really had paid much attention to. You know, my first reaction would be to say that there really hasn't been, but I feel like that's just a very surface level understanding.
Mm-hmm.
Hard to throw that at you without any preparation, but maybe as I was listening to what you were saying.
I haven't noticed necessarily any differences. So if there are, it's subtler. It's not something that would necessarily be a big pattern that would be like a bright red flag. If I can share, one of the things that I have noticed to a degree is that some of the people who've been coping the best with the changes are people who have already been through traumatic circumstances. And it's not that they're not struggling, it's not that they don't have their difficulties, but in a sense, having their entire life disrupted and old patterns being suddenly torn up, it's not entirely new to them. And so there's a familiarity and an opportunity for some folks who have been through maybe not a pandemic, but who've been through trauma and who've been living with anxiety and depression and working on that for a long time. Those those are some people who I've noticed have been more resilient and been able to bounce back better and to adapt and to really make use of the opportunities that COVID has opened up. That's not a universal observation, but at least with a notable number of folks, that's been something that I've seen. I don't know, Shannon, what you've seen.
Yeah, no, it's interesting that you brought that up, because I always do what I call like a COVID check-in, right? I use a lot of humor with my patients, and the individuals that I'm working with complex trauma histories, they kind of breeze right past that, and we get right back into, you know, the material that we had been working on previously.
That's actually quite interesting. I imagine there will eventually be studies about this for future clinical references. I wonder how this also, I mean, my first question was about differences between male and female, but I'm wondering if you've noticed different impacts based on, and Shannon, you mentioned language issues or cultural issues being something that exacerbates this, but I also wonder in terms of LGBTQ plus clients or people of color clients, whether those, I mean, that's a wide variety there that have also different challenges in terms of, say, immigration, or whether they're African American or Hispanic, things like that. I wonder how different marginal groups are dealing with some of these challenges. Whichever one of you wants to speak to that.
Go ahead, you can start.
Okay. It's interesting. And I think this is an important thing to keep in mind, is that at least from what I've seen, that again hasn't necessarily made a difference. At least, you know, it could just be my caseload and the particular folks who I'm working with most directly. But my sense is that the role that, you know, race and sexual orientation and gender identity, the role that they've played is they've been sources of stress and microaggression and minority stress and trauma. But they're, in the case of COVID, those pieces aren't necessarily the ones that are highlighted. So they've been more in the background. And the conversations that I've had have around coping and dealing with the stressors of COVID has been around things like relationships with family, and you know, social barriers and social problems and so forth that have been exasperated, but not necessarily at the center. So it's more kind of set up the groundwork and the framework for the work that we're doing around coping with COVID, but it hasn't necessarily been front and center. I don't know if that makes sense at all.
Yeah, no, it does. I guess part of this question comes from observing some of my students who, you know, they're young and were out or newly out in terms of their sexual orientation, identity, or gender identity on campus, but they had to go home when we shut down, and that changed their social dynamics. Now, I'm not implying that they were in therapy. I have no idea, but it just does seem to me that for some populations that actually might exacerbate, you know, for example, having to go back in the closet to survive at home when they had that space and community on campus, just as an example. So I guess that's sort of the genesis of that question, but it's more observational than anything else.
Which would be interesting too, because you would wonder, you know, an individual like what you're describing, they may not be in therapy, right? They may not be at that point, and so they're struggling with this perhaps on their own. or reaching out to a limited number of friends. And, I don't have many individuals that would fall under that, kind of umbrella on my personal caseload. So I can't speak to it directly, but I think that makes sense.
Yeah. And I think that one of the things about COVID that makes it hard to notice the differences among either gender or sexual orientation or race or ethnic group, so forth, is that it has, to a degree, impacted everyone. There are lots of people who are suddenly finding themselves cut off from their usual social supports. There are a lot of people whose routines have been completely disrupted. And so, a newly out lesbian, going home from school where she had a community and then had to go back in the closet or so forth. That's a unique kind of flavor to the experience, but my sense is that it's not necessarily fundamentally different than the example I gave before of somebody who's in addiction recovery suddenly being cut off from their social supports. So while some of maybe the nuances and the individual aspects are different, my sense at least is that there's a common thread and a commonality across them that, some of the details may be different, but the underlying experience is relatively similar.
Mm-hmm. Where I've seen the greatest difference for me with my population is not so much with coping, but with access. So for example, like working with, people of color on the east side of Buffalo, they weren't able to hoard, right? At the start of all of this, they were, asking for supply donations for, Lysol, cleaning supplies, gloves, masks. They had no access to any of that, to even be able to go to a grocery store and, stock up for a week is kind of a luxury for many of them. And, then they're hearing kind of the end of days, that was, I think for me, like I feel so removed from the start of COVID now that it's hard to kind of go back and remember everything. But I mean, it was scary, right? And so a lot of individuals were starting to panic and worrying about, and, so I saw the community really come together, but then they also weren't able to participate in social distancing or social isolation the same way that I saw some of our, middle, upper class white individuals being able to do.
No, that's the thing about this pandemic is that it seems to have shown in greater relief and detail the inequalities that have always been there, but we have been able to ignore more easily as a society. The hoarding thing was one of those things too that I observed. I mean, I'm not poor, but I noticed that like going to the store, okay, I have a car that can get me there and that can carry the groceries home. I don't have a place to store all of them, but I noticed like that things were just wiped out. And I'm thinking, where are you storing them? You must have like multiple refrigerators, a deep freezer, a pantry, and a gigantic SUV to carry all this stuff home. And if I'm complaining about it and I still have a lot of privilege, I can only imagine the effect on communities that have much less access to those things and much less easy access to those things. And I that's just one example. I mean, just the access to healthcare or technology, as Stephen mentioned earlier, which I also noticed among my student populations, their access to, there's one computer in the house and the entire family shares it. And you have a set time when you are allowed to use it, that sort of thing. And I think that often we are unaware of those things, and that this crisis has maybe shown more of a light on that, and hopefully people are more aware. I want to maybe go to a couple things, and I'm trying to figure out which order to do this in, but both of you in different ways have mentioned about sort of group trauma and response to it, as that we've all gone through it, but we're also going through it differently, as we've just discussed. And so while there's a commonality of going through it, there's also, we're not going through it the same way, right? And I wonder if you see that, and I don't mean, this question is less about individual therapy practices and more about sort of cultural observations. How you see that playing out on a broader cultural spectrum. And I guess in my head, if I can make this make sense, this is connected to Black Lives Matter and the protests, because because to me, that's also a cultural trauma. It's a cultural trauma that not everybody goes through. Mm-hmm. And yet these two traumas, COVID and racism, are converging in interesting ways, partly because of the time frame in which these things are happening, partly because I feel as a result there is a cultural space, a sort of pause. People are working from home or not working or furloughed or under different sort of stressors. And I see these things dovetailing in interesting ways. And it's also June, which is generally Pride Month, which is generally other celebrations that aren't happening. And I just wonder sort of what you see on a broader cultural perspective about trauma, and how that is playing into this particular social moment, both in terms of race issues, health issues, and LGBT issues, which are sort of intersecting in powerful ways that I hope are sustainable for deeper changes. But sorry, that's a big, heavy question. But
Well,
go ahead.
I'm wondering if it would be helpful if we start and kind of take a step back and if I say just a little bit about what trauma means in a clinical sense, because it's a word that has sort of its technical meaning and it has its sort of common meaning or its medical meaning, and in a clinical sense, and Shannon may have sort of a different framework for thinking about it, but the way I approach the idea of trauma is that there are two pieces to it. Two parts of the experience that make it traumatic. And the first is that there is a threat or a very heavy stress of some kind. And this can be an experience of violence of any kind. But it can also be, I mean, the philosopher in me wants to use the term an existential threat. Some experience that shatters your sense of who you are or makes you really question what kind of place the world is, and that can really just cause this seismic shift in how you understand yourself as a person in the world, and violence can do that as well, and so those can go together, but it doesn't necessarily have to. So any kind of experience that causes that threat to yourself, whether physically, whether your health, your mental health, your loved ones and relationships, or even just your sense of self in the world, that threat or that heavy stress or burden placed on that is one piece. And the second piece that makes that traumatic is that our brains don't know how to cope with it. And so we have this huge, dangerous threat that we experience, and it's very experience-based. What one person experiences as traumatic won't be the same for another. But we have that threat and we don't know how to deal with it. And this literally changes how our brains function. And what happens is the threat puts us into fight or flight mode. So we go into survival mode. And the fact that our brains, even if rationally we do, the survival part of our brains, the very more evolutionarily older emotional survival parts of our brains, doesn't know how to resolve it. So that fight or flight mode stays active to a degree. And everything that you experience and everything that you see in terms of trauma it may not make sense rationally, but it makes a lot of sense in terms of these are survival skills. These are our brains going back to our most basic, primitive, hardwired and learned behaviors that have kept us alive. And so I think even talking about cultural trauma and trauma on a large scale, it's important to keep in mind from that framework that everything that you see, you might be able to reason about and have an abstract, philosophical argument about it. But ultimately, what's at stake in that moment is survival, and everything is geared towards survival on the physical, emotional, mental, or social and existential levels. So I think that's an important thing to understand. If we're going to be talking about cultural or social trauma, keep in mind that there is a threat. It can be that threat to our sense of self, and the ways that we respond to that are survival responses. They're aimed and based on what we've learned will keep us alive, not necessarily thriving, not necessarily living our values or some kind of wellness, self-actualization, but just to keep us alive. And that's the basis of trauma. And I'm Shannon, I see you nodding your head. What are your thoughts, or what you have to add?
Absolutely. And the only other thing that I would add to that is, I think it's important to understand that like our brains can't differentiate emotions in terms of time, right? So if we're feeling angry, our brain is saying we're angry right now, whether that's because we're recalling a memory from the past that made us angry, or we're anticipating feeling that in the future. And so when we are experiencing that sort of fight or flight, right, that survival mode, we are in the right side of our brain. We are in an older part of our brain that is focused, again, right, just on that survival. And so we're there and we're feeling it immediately as if it's happening right now. And so, when you're talking about sort of this cultural or even intergenerational trauma, those experiences are very much lived right now in the present.
Mm-hmm.
So I guess, sorry, as someone not trained in your field, do you see this moment with COVID and the race protests and LGBT decisions by our government and by the Supreme Court and the cancellation of, do you see these things from a trauma point of view, sort of culturally speaking? I mean, is that a fair assumption to look at them that way?
I won't speak for Shannon. I will say that I do.
Uh-huh.
I was going to say my bias is I think everything has a trauma basis. But,
okay, I think we share that bias.
My clinical work.
Mm-hmm.
So then how do we culturally respond to that trauma?
Mm-hmm.
So, sorry, I don't want to cut you off, Shannon.
No, go ahead. I was just thinking like that's, I don't know.
Mm-hmm.
I don't know, right? That's a heavy question.
Yeah, I think one of the first steps, and then there are two kind of steps here. The first is recognizing what exactly is a trauma response. We talk about fight or flight mode. There's also the two other Fs, which are freeze or feign death, pretend that you're dead. So you run away and avoid, you fight, you pretend that you're dead and shut down by freezing or even more, I guess you could say, drastic or more intense kinds of shutting down. And I think when we look at different responses, we can see that, especially we see the, right now we are seeing a lot of the fighting back. Pride, the first Pride, Stonewall, was a riot, people fighting back. You can only live under threat for so long before you're going to have one of those responses, and recognizing that aspect, that this is survival in response to a threat, I think can help us to recognize both in ourselves and in our social discourse the ways that so many of the conversations get it wrong. The ways that people who have not been traumatized by racial violence think about the responses of like, oh, well, how could you do that? Like, that's just not relevant. You don't understand because you haven't had the experience needed to understand. Mm-hmm. So learning more about recognizing that these are deep-seated survival responses at both the individual and the social level, I think can go a long way towards helping us to recognize what is the problem and what's the symptom of the problem. Looting, which is, there's so much problematic about the complaints about looting that would be an entire different conversation. But if you're concerned about looting, then what you need to do is get to the reason why that's happening. And that is the core. You don't treat the symptom, you treat the underlying cause, at least from a mental health and even medical perspective. So that's a red herring. That's a distraction from the real issues, which are social justice and dismantling white supremacy. And that is, from a mental health perspective, at least my idea of a mental health perspective, that's where a lot of our social discussion and our social responses get it wrong. And there are a lot of reasons for that, which you don't need me, the white guy, to sit here and talk about. But ultimately, it comes down to that: what is the harm, not what is the symptom of the harm. And understanding, that asking what's wrong with someone that they're having these behaviors is the absolute wrong question. The much better question is, what happened to them? What are the experiences that brought someone to this point where this is what they need to do in order to survive? And I have my part too, but Shannon, I want to make sure.
No, I'm like, go for it.
Okay, so part two. One of the things about trauma that is very prevalent is that trauma isn't just about survival, and it doesn't just disrupt how we approach survival and what it means to live and to thrive and to survive. It is also deeply rooted in relationships. Oftentimes, trauma comes about because those relationships have been violent, or those relationships have been ruptured. And one of the most important, and probably the core of healing from trauma, is building those healthy relationships. And at the individual level, that's a lot of what we do as therapists and counselors, is, build that relationship and keep showing up and being that consistent adult, relatively regulated example of what a healthy relationship can be, and what the possibilities for a good relationship can look like. And my sense is that at the cultural level, both the Black Lives Matter movement and Pride and all the movements for social justice and social change fundamentally is about relationship, and how individuals in different communities and how those communities themselves relate to each other in terms of not just interpersonal relationships, but in terms of law and policy and social structures and institutions. There's a relationship element that I don't think necessarily gets brought up directly as much, but healing isn't going to be possible from all of the homophobic and transphobic and racist and white supremacist and nationalistic garbage. That's not going to be possible until we find a way to start building that social relationship. And that requires social change, because it's not just relationships among individuals, it's relationships of individuals to systems. Mm-hmm. So from a trauma framework, that's at least how I see it.
Mm-hmm.
I have some follow-up questions on that, but Shannon, what are your thoughts on what Stephen has said?
I mean, I agree, 100% with everything. And the thing I keep coming back to is just that it's so interesting, because, what we're talking about is something that has been in place for a very long time, right? It's systemic. And yet, why now, right? Why at this time? Why is it that we're able to make these changes? And, I think that, again, it kind of goes back to the inequalities that COVID highlighted, and the fact that we're at a point where a lot of individuals are feeling like they don't have anything to lose. I had posted an article about how, again, unemployment rates for for African American communities are once again the highest that they've been in years. And we're not working. We already are disconnected from our families or our communities, or seemingly disconnected. And so we have that time, and we have the sense of it's now or never.
So just some follow-up thoughts, questions, things I'm trying to work through myself. It seems to me that the rhetoric around defund the police is actually about some of this as trauma response. Because if people look at it and say what we should be doing is sending in mental health people or social workers or treating these things different, it seems to me that that's what that conversation is about. It's misunderstood as something else. But it seems to me that that's what's driving some of these conversations about why are we policing instead of relating? Why are we using force instead of building relationships? And I hadn't thought about this way until you mentioned that. So I just want to make sure that I'm actually reading that correctly, that what some of these movements are that are misrepresented or misunderstood are actually about building relationships, not policing relationships. Would that be fair to?
I would say yes. Yes, it's about building a very different kind of relationship, because, an abusive relationship is still a relationship. And that's the one that I think currently exists. And so that question, Shannon asked an important question, why now? And there's sort of a corollary or another question that goes along with that, which is why is that, why, the police and police violence, police are not the only institution that systematically and systemically oppresses and abuses people of color in this country. So why is defund the police, and why is the focus on police brutality coming up? I think that also speaks to the severity of the abuse that occurs on that level, and the ways that the police are, the ideals of what they're supposed to be, and the rhetoric around police and law enforcement, I think does a lot to shape that traumatic relationship. We can trace back why now. Well, we also live in a post 9/11 world. And for those of us who lived, we're alive before 9/11, and seeing the shifts that came there, and the ways that communities became much more entrapped in surveillance cultures, and the ways that, just putting on any uniform at all automatically got you, labeled a hero. And it didn't matter the content of your character, didn't matter what you did in the job. You were, if you put on the uniform or you signed up for that, you were a hero, and that was unquestionable. And anyone who questioned that hated America and hated our freedom. And there's a lot of gaslighting and abuse and just manipulation around how the police and law enforcement are thought about and talked about in our culture. And I think that is a contributing factor to why, defunding the police and focusing on police brutality and the systemic oppression in law enforcement, and that comes out of law enforcement. I think that's a big part about why that is been the focus as well. But I mean, that's just my view. So I don't know if that's necessarily accurate or correct, and I'm sure there's a lot more to it, but what are other thoughts?
It seems to me too that it's also because it's maybe the most visible aspect of systemic problems, that's maybe why that focus is there, because we see it in ways that we don't see other forms of systemic oppression and violence that are more maybe subtle or psychological or cultural rather than something visible with tear gas and batons and pushing old men down to the ground. You know, I suspect that, and what I fear is that focusing on just that is not solving the greater relational systemic problems that we have as a culture. Brandon, do you have any thoughts on this?
You know, I mean, I agree with you on that. My fear is that if we only focus on the police, right, we're segregating again. You know, we're creating divides where we really need to come together. You know, when I listen, you know, both clinically but also in my personal life, to the conversations surrounding everything that's been happening in Buffalo lately with the racial protests, you know, that's my biggest sadness, is that you see these divides starting to grow. And again, people latch onto certain elements or aspects, and it's much harder, you know, like I keep going back to your point of it's the most visible. It's much harder to see some of those other forms of oppression and, you know, racism. And I'll never forget, a Black woman once told me, she said she remembered by the time she was 5 that people could hurt her because she had a different skin color. But by the age of 7, she realized that people hated her because of her color. And now this is a woman, she has a PhD, she's done, you know, years of therapy, and was able to have that awareness. And I compare her to some of the kids that I work with in the community that are not at that level. They can't voice that. They don't understand it, but they can look at, you know, the way that they're maybe profiled by police rather than how I would be profiled.
So what are some strategies that we can use to sort of try to shift the cultural conversation about this to understand this through the lens of trauma, and not, oh, those looters, a bunch of criminals if they just obeyed the law? Or you know, how do we move from this place of being stuck and increasing divisions and tensions and traumas? How do we, like, sorry, I'm asking you to provide a therapeutic cultural solution, but how are ways what are some strategies that can be used about this discourse that can successfully and therapeutically change this? Because I feel that everyone's a victim here to different degrees, but there's victimization that's happening that is helpful to no one. And I wonder if there's ways to explore this that can provide sort of a therapeutic way forward. I don't know if that makes sense, but
It does. You know, I think it goes back to what Stephen was saying. We have to stop asking, you know, what's wrong with them, but what happened to them. You know, and so for me personally, I try to bring that level of awareness into culturally sensitive conversations. And in my work, you know, that's one of the goals of Brave, is to help these individuals that are coming to us, you know, with gun wounds, victims of gang violence, to say, you're a victim as well, right? And for many of them, that's the first time they've ever been shown that sort of empathy or had an understanding that, you know, they've suffered as well. And I know that's a much more micro level, but I believe it starts with one.
right. Do you have any thoughts on that, Stephen?
I do, and especially coming from sort of the lens we've been talking about is this is a social level of trauma. With any kind of trauma work and trauma healing, the first step always is and always needs to be creating safety at every level of the person, in their environment, mental safety, emotional safety, physical safety, creating that safety. And I think that also speaks to why the focus on the police and law enforcement is is one of the primary conversations, is because that's one of the primary sources at every level of a lack of safety. And that is, you know, the police is in many ways a tool that is used in our systems to police and to enforce and to punish and to bring people into the system and to keep them there. And so there is a fundamental lack of safety in that relationship. And part of that, I think it's important to remember, you know, looking across different racial communities and racialized populations, it's important to remember that my sense of what is safe and what will create safety is going to be very different from other people's. You know, as a gay male, my sense of safety is different than a straight person's. As a cisgender male, it's going to be very different than a transgender person's sense of safety, and who is safe and what kind of spaces are going to help them to build that sense of stability and safety. And that's going to be especially true in these conversations, that as a white person, my sense of safety and what I can do and what I need to do is going to be very different than a person of color or an indigenous person's sense of safety. And that's where I think we need to be careful. And I think this is one of those places where those clinical therapeutic skills can really come in handy, which is kind of bracketing off our own experiences and our own expectations to really let the other person speak what they need to speak and to say what they truly need, which is why as a white person, I need to learn to shut up. And Shannon, you mentioned something that I feel it would be important to respond to and that's if we're thinking about our current social movements and Pride and Black Lives Matter and all of these pieces, if we're going to look at it from a trauma framework and a social trauma, which is of course not the only way to look at it, but if that's what we're doing, then we have to keep in mind, I think, and I'd love to hear your response, but I think that we need to look at it from the point of view that the systems are perpetuating that trauma. Mm-hmm. And in that sense, it's very, I think, closely analogous to an abusive relationship. Mm-hmm. And at least my sense of what healing looks like is you got to be really careful about talking about or bringing in the abuser and the abused. And sometimes those divides need to happen. Sometimes there does need to be some separation and a break. Until that safety is there and until the abuser has done their own work, I at least am very wary about the idea of bringing them together, because there's a power dynamic there. And there's, especially when it comes to systems like law enforcement and criminal justice, and even our economic systems, there's a huge power differential. And that's something that needs to be addressed before those relationships can be transformed on a more personal or more, I don't know what the word is, but before we can get to that place of overcoming the divides, those systems need to be changed so that there is the possibility for safety. And I'm wondering what you think about that. And if I understood you correctly, I may have gotten you wrong.
Well, I agree. There is a larger, there's larger issues that need to be addressed, right? It's this whole systemic change. And I guess maybe I take it more from like a solution focused of we're here right now and we have to have you be able to survive in this world right now, right? I don't know if that makes sense. So it's more focusing on, if this is where we're at and this is the reality of our world, how do I find ways to fit into it right now while also then working towards those larger systemic goals? And I think that's where sometimes, I personally feel overwhelmed, is because that change isn't going to happen overnight, and so, I'm working with individuals that they need to survive until tomorrow, right? How do we get them through to that next day? you know, and so I always, again, right, like I use humor. I'm like, it sucks, right? I'm telling you that your abuser is still going to be here. And again, kind of speaking to what you were saying of like, how do we make you safe? How do we create that sense of safety and autonomy in a culture and a society that's broken?
If you'll permit me, I want to make a little plug for the humanities here, because I sort of feel that one of many responses is following up on what Stephen said about a place to speak, is making sure that those voices have that place in your literature class or in your film class, or when you pick up what to read or what to watch or what to listen to, that one's choices in that regard are also mindful of these voices that are trying to speak to that and educate. And I think that literature and film and the arts have a place there, and that is often viewed suspiciously or poo-pooed as not important. But I really do think that humanities can have a place in a sort of a therapeutic place in this sort of group national trauma. And philosophy, of course, falls and I wonder, do either of you know Rafael Campo and his work? If not, I'll send it to you, because he's a medical doctor, so not a mental health doctor, but a medical doctor. But he looks at how literature is part of the healing process for people. You have to heal sort of the soul in order to also heal other things, and that might be something interesting to you. I'll send that to you.
Absolutely. We used to run a bibliotherapy group at ECMC where we use literature to teach empathy and social skills to individuals either with chronic illness or traumatic brain injury.
Oh, that's fascinating, because that's actually the term that he uses, is bibliotherapy. Oh, that's fantastic.
Yeah.
More of that.
Yeah. Yeah, I agree wholeheartedly. And for years, literally for years now, that has been part of my mission as a social work educator, as someone who lives in both worlds, because I don't think I ever stopped being a philosopher. I just not teaching it for a paycheck. But I think, the analogy I use is the analogy of mountain climbing. And yeah, of course, you need the skills and the tools and the rope and the pulleys and the boots and all that. And you need the skills to climb up the mountain, but you also need something at the top of the mountain that you're climbing for. And at least my experience, in my sense of a lot of at least social work education, but also clinical education, is that there is a huge focus on the first. And we're very much teaching people how to be technicians, in a sense of, here's how you do cognitive behavioral therapy, or here's how you do solution focused, or here's how you do this particular therapy. But there is very little discussion about that question of like, well, what does it mean to live a good life? What are we teaching these people skills for? There's sort of this like shallow, political liberalism of just like, well, take your hands off and people will figure out happiness for themselves, as though that's something that anyone has ever been able to actually do. And I think a big part of mental health and COVID and ways that we can be better about addressing these pandemics, whether it's the pandemic of coronavirus or the pandemic of racism, is to get back to our roots and really take a look at, professionalization and licensure and clinical education, because it is so narrowly focused on, here are the concrete skills, here is how you interpret the Diagnostic and Statistics Manual, which is the list of the criteria for all the psychopathology and all the mental health disorders. Here's how you apply that, and here are the basic skills of what you do about it, but without that bigger picture of what we're doing that for, and how we can help people to imagine new possibilities for their lives. You know, it's like, it's teaching how to do an assessment, but not teaching what are you actually assessing. You know, what does it mean to be a person in the world, and how do we actually live and interpret and express and make sense of our experiences, which is what the humanities is largely about. And that's completely absent in an education system that focuses solely on a very medicalized model of social science and social science research. And so I think one of the things when we're thinking about mental health and the role of mental health in healing from and addressing pandemics, we need to think about how are mental health professionals trained and educated, and what is the framework that we use for that.
What you say is so interesting, Stephen, because I see this in academia on a broader scale too, is the complete gutting of humanities in favor of STEM, which is driven both administratively, but it's also driven by where students are taking classes, and the lack of sort of integrating these things into a more holistic conversation that makes better doctors and makes better therapists and makes better, you know, better professional people. And that's why I also enjoy reading your posts about your philosophical musings about teaching mental health training. Shannon, do you want to follow up? And then I have just 2 more questions.
I think we're good.
Okay. So I wanted to ask 2 more things. And one of them is, how is the COVID, the quarantine, and consequent social changes, how have those things affected you, and how do you cope within your practice?
So for me, I'm still working full time. And so it's almost like that idea of nose blindness. I think that it's a shock to me to go out into, you know, kind of the real world and see individuals that are still struggling with the fear of contracting COVID. You know, working in a hospital setting, you are continuously exposed. You know, and so the most difficult part for me personally was that the lack of access to my coping strategies. And so trying to figure out how to sort of regroup and reconfigure so that I could handle the level of support that became necessary for many of my patients. You know, I found that I had, you know, and maybe Stephen can speak to this too, you know, I had a lot less cancellations. You know, people, whether, I don't know if it was because it's more accessible for those who have access to technology with the telemed, or if it was just that need for social interaction. You know, but I would see individuals, you know, more than once in a week, you know, or we would be able to do a few more hours during one session. And I'm really fortunate to be able to do that because I work under a federally funded grant, so I don't have to take insurance or worry about pay.
Yeah, I would echo all of that. Sorry, go ahead, Richard.
No, I was just going to say if you wanted to follow up with that.
Yeah, I would echo all of that. I've really had to rethink my own coping strategies. Like, I can't go to the gym and move heavy things around for a while as a way to turn my brain off after work. So I've been having to really try new things and adapt. And you know, Shannon is absolutely right. I have far fewer cancellations and no-shows, which is a whole nother level of stress because the amount of paperwork goes up, it doesn't go down, but the amount of time goes down. So definitely everything that Shannon said. And if I can add one more level to that, it actually gives me hope. You know, one of the things, as Richard, as you said, our assumptions of, or the things that we had been able to keep hidden as a society, they're out there. And people have to see it, or be willfully ignorant of just all of the things that are so broken right now. And the fact that, we're shining that light on things, and all the ways that people are left behind and left out, and hurt by our current systems and ways of thinking and ways of doing things, that I think is important. And I think, like you said, that's a big reason why Black Lives Matter has really been able to reemerge more publicly and get a lot more of the attention, is because so much of that has been laid bare. But even just from the mental health service side, we've had to rethink how we do things, and we had to rethink what's important and what's possible. I have some patients who I don't even know what they look like. I've never met them face to face, and we've only talked on the phone. And even then, one such patient, at the end of a session not too long ago, she broke down and cried and said that she loved me, just for and totally like HIPAA compliant, not like a boundary violation kind of way, but we were able to have that relationship. And I think even 5 months ago, if you had said to most counselors or therapists that that's possible over the phone, I think a lot of them would have been skeptical. But we're experiencing that, and we're experiencing people in a very different setting and getting a much better sense about what their actual lives are. So we're able to imagine, I think, new possibilities, that humanity's approach. Mm-hmm. And something else that gives me hope, and this may be a little bit cynical, but one thing that COVID-19 has proven is that we can stop what we're doing and turn on a dime. All of our systems, our service delivery system, our healthcare system, our economic systems, all of these systems, we can stop and turn on a dime, which gives me hope, because when people say, oh, we can't make those changes, no, we can. We need the political will, and we need the reason to do it, but we can do it, and we know that because we did it. So it can be done. And my hope is that, especially those of us in direct service, will be able to kind of break out of the often kind of assembly line type model of session, and say, what? We prove that we don't have to do it this way. And hopefully we will have the political will and ability and momentum to really push through those changes, because we can. We did it, so we know we can. And so I have hope for the future, and I hope that those with the power to make those changes listen to this, and they take that seriously. And I hope they're a little bit uncomfortable and maybe a little afraid of what the pandemic has shown is possible for our entrenched systems and ways of thinking.
Mm-hmm.
I'm so glad that you mentioned that, Stephen, both because I want to have sort of a segue into something happier, but also because this notion of change, I think we've been sold on the idea that change takes time and stuff. And what, as you said, what this has shown is that if there's will, we can change, and we can change rapidly. What's so disturbing to me is that I was in a meeting the other day, and someone's like, well, we can't change that fast. And I was like, excuse me, we just did 2 months ago or 3 months ago, like that.
Yeah.
Changed. What are you talking about that we can't change these other things? And this was a conversation about race issues. Like, if we want to, we can. And I think that you're right, that's a source of hope, because now there's proof. We did it. So I guess maybe to conclude our conversation, I don't want to ask if there's a silver lining, but are there positive opportunities that, and Stephen has talked about this to some degree, but are there other positive opportunities that have resulted from the COVID pandemic crisis that may have more longer and positive impacts, both either on a therapeutic, level or on a broader social cultural level.
I believe personally it goes back to that idea of relationships, right? And just our ability to connect with one another. I've seen, I think that for me is the most positive thing that I've seen, like, again, kind of on an individual level, is that people are recognizing the importance of reaching out to others, of having others in their lives. And again, right, the fact that looks different for everybody, right? And everybody has a different need, but starting to recognize and acknowledge those needs.
Are there positive opportunities besides hope, Stephen?
I think so. One of the things that, even as a mental health counselor, I need to remind myself of is that in my work, I tend to see the sickest of the sick and people who are doing the worst. And that's true whether it's in addiction work or whether it's in mental health or social work in general. And it's easy to take what I see every day as the baseline. And that's not true. The fact is, and the fact that that I need to remind myself of is that, as a matter of fact, most people do just fine. The vast majority of people do okay. Doesn't mean they don't have struggles. It doesn't mean that their life is perfect, but they do well enough by their own standards, and they're going to be okay. And there are reasons, especially in the case of trauma. Our brains are wired to focus on the negative. There's a negativity bias just built into our thinking. If you've ever gotten that email or that evaluation where it's like, here's 30 things you do wonderfully, and one thing that you could do better, it's like that one little thing is like, you're both smiling because we focus on the negative because that's just how we work. That's just human cognition and thought. And trauma exasperates that. So it's really easy right now to see all the darkness and all the despair and just let that be overwhelming. But something else that both my work as a philosopher and as a social worker has taught me beyond any reasonable doubt is that we have a lot more power over that than we give ourselves credit for. And it's not easy, and it takes work, and it takes a daily effort, but we can change that. We can make that choice to acknowledge the bad, but to focus on the opportunity and the possibility and the hope and the healing and the things that so many people are doing to fight back, to thrive, to survive, and to transform this world into a better place. And so that's something that gives me hope as well.
Mm-hmm. The thing I love most about people is that we're resilient. We always find a way to perpetuate, to live.
Well, that's two very positive things to focus on. And so I want to thank you both for what for me was a very enlightening conversation. And that also, it gives me hope as well, because it is sometimes difficult to find that these days. And so, and I want to also thank you on a personal level for your friendship. That is a coping mechanism for me as well. So I appreciate that. And hopefully we can reconnect soon in person. I miss Stephen's hugs. He's quite a
we all have a
hugger, I guess. And Shannon, we had met, I think in January, planning future coffees once a month, and
it didn't happen. COVID happened.
Yeah, COVID happened instead. But I'm glad that we can still find ways to connect and talk with each other and continue doing good work.